minute. Okay. Go ahead.
Okay. Good morning, everyone. I want to thank you for the invitation to speak this morning. The title of my presentation is Gastrointestinal Concerns in CDKL5 Deficiency Disorder. My disclosures include the following. I'm a section editor for Up to Date, an electronic textbook of medicine. I do not have any financial relationships with any manufacturers of commercial products or commercial services, but I will list some unapproved uses of some commercial products for children in my presentation. Parents frequently have a number of concerns about their children with CDKL5 deficiency disorder. The concerns that I hear most often include the following. My child eats all the time, but my child doesn't gain weight. My child vomits all the time. I know something is wrong. And my child won't go to the bathroom unless I give him or her something to help. I don't want my child to become addicted. The point that I want to make about these comments is that they reflect motility disturbances throughout the gastrointestinal tract. And these problems are often common in children with CDKL deficiency disorder. My objectives for the talk today are fourfold. By the time I finish, I want you to be able to recognize problems related to gastrointestinal dysfunction in CDKL5. I want you to be able to recognize symptoms or signs that may prompt a call to your physician. I want you to understand the rationale for selected GI tests. And I want you to understand the approaches that we may use to treat the gastrointestinal dysfunction in CDKL5. This slide summarizes the common gastrointestinal problems that parents reported to us in about 60 children with CDKL5. The data is taken from the Rare Disease Clinical Research Network database. About 2% of parents reported chewing and swallowing difficulty. About 70% reported gastroesophageal reflux. About 46% reported gastrostomy. About 40% reported aerophagia or air swallowing. About 12% reported abdominal distension. About 67% reported diarrhea. And finally, 82% reported constipation. I want to make a few points about the data that we have on the prevalence of gastrointestinal issues. First, the number of children with CDKL5 that were captured in the database is small relative to the number of children with other genetic syndromes in the database. Nevertheless, the prevalence of constipation is quite similar between CDKL5 and other genetic syndromes. Second, gastroesophageal reflux is nearly twice as prevalent in CDKL5 as it is in some of the other genetic syndromes. But this point actually has a little bit more discussion that needs to be explained. And I'll come back to that in a little bit. Third, chewing and swallowing difficulty was reported in only 2% of the children with CDKL5, a number strikingly less than the problem in children with other genetic syndromes. I think this percentage is underrepresented in the children with CDKL5 because in reality, approximately 46% of the children with CDKL5 have a gastrostomy, suggesting far greater problems with chewing and swallowing. Now, the question is, why do we see gastrointestinal problems in children with CDKL5? And the short answer is we really don't know. We have some evidence of abnormalities in the gastrointestinal tract, two of them being the enteric nervous system and the intestinal microbiome. In the enteric nervous system, we suspect that gene mutations may alter synaptic transmission and neurotransmitter synthesis and activity. In the microbiome, we suspect abnormal patterns of microbial colonization and metabolic end products that alter the gut-brain and neuro axis function. Both of these topics are areas of active research at the present time. So I would like to focus on three problems of the gastrointestinal tract that I commonly see. The first one being chewing and swallowing difficulty. Children with CDKL5 deficiency have a good appetite, but they have decreased eating efficiency due to chewing and swallowing difficulty. Chewing difficulty is characterized by poor mastication and poor tongue mobility. Swallowing difficulty is characterized by drooling and choking, particularly when drinking liquids, but also when eating solids. The complications of chewing and swallowing include malnutrition, low bone mineral mass, and aspiration with or without pneumonia. I become concerned when I hear the following types of issues. Prolonged feeding times, where it takes a parent longer than 30 or 45 minutes to feed a child a meal. Coughing, choking, or gagging with drinking liquids or eating solid foods. Children who have an oral aversion or frank feeding refusal often have difficulty chewing and swallowing. And progressive weight loss, poor weight gain, or a body mass index consistently less than the 5th percentile often reflects chewing and swallowing difficulty. We have two types of tests that we can do to evaluate the chewing and swallowing difficulties. The occupational therapist will do a visual feeding assessment by watching your child drink liquids and eat a solid meal. Speech pathologists will do a swallow function study using different food consistencies, including thin and thick liquids, purees, and crunchy cookies, all laced with barium, to assess feeding skills, including jaw movement, tongue motion, and the initiation of swallowing, as well as some safety issues, including laryngeal penetration and frank aspiration of liquids and solids. The X-ray on this slide demonstrates an abnormal swallow function study. If you follow the white line of barium from the mouth through the pharynx, you can see the thin line of barium as it passes into the throat and slides into the larynx just before the initiation of a swallow. The importance of this finding is that chewing and swallowing dysfunction places the child at risk for aspiration. The treatment approach to chewing and swallowing difficulties is actually limited. Occupational and speech therapists focus on therapies to improve the oral motor feeding skills. These therapies include postural alignment, oral desensitization, jaw stabilization, and tongue organization. They may recommend the use of thickeners for liquids or pureed table foods. Appetite stimulants are not useful for oral motor feeding problems, and we have no evidence for the benefit of the use of vital stim, which is an electrode that can be applied to the neck to stimulate the muscles associated with swallowing. With respect to malnutrition, the body mass index is the best test to assess nutritional status of the child. The body mass index is a measure of the relationship between weight and height or length converted to percentiles. The BMI for children changes depending on the age of the child. In children without a genetic syndrome, a normal BMI follows the 50th percentile. In children with CDKL5, a normal BMI is a moving target because children with CDKL5 may have genetic downsizing, which means their height velocity declines over time and they remain smaller as they get older. Consequently, in prepubertal children, a BMI in the range of the 25th to the 50th percentile may be normal, but in postpubertal children, a BMI in the range of the 5th to the 25th percentile may actually be normal. A red flag for me is any child whose BMI is persistently below the 5th percentile. We have two diagnostic tests for low bone mass, but often do not resort to testing for this particular problem. The cause of low bone mass is probably multifactorial, including small body size, immobility, anticonvulsants, and an inadequate dietary calcium and vitamin D intake. A radiologist may use a skeletal X-ray to assess poor bone mineralization or fractures. In this slide, the washed out appearance of the digits in the fingers on the hand illustrate poor bone mineralization. A radiologist may use a Dexa scan, which is an X-ray of the whole body, to assess total body bone mineralization. A Dexa scan may be difficult to obtain because children need to lay very still during this test, and any motion negates the interpretation of the scan. More importantly, a nutritionist may review the child's milk and dairy product consumption to ensure that the child meets his or her dietary calcium requirements for age. And the physician may order a vitamin D level to be sure that the child is not vitamin D deficient. The treatment approach for malnutrition and low bone mineral mass is a nutritional therapy. We may use supplemental formulas to provide an additional 500 to 1,000 calories a day. We would consider a gastrostomy button placement for a BMI persistently less than the 5th percentile. We encourage parents to provide an age-appropriate milk and dairy product consumption as 2 to 4 cups of milk or yogurt a day to ensure adequate calcium intake. And we recommend that parents provide a multivitamin supplement to ensure a vitamin D intake of approximately 800 to 1,000 units daily. The second problem that I want to discuss is vomiting. Vomiting in children with CDKL5 poses a different type of problem. Chronic vomiting usually is due to gastrointestinal reflux or gastroparesis, which means delayed stomach emptying. Gastroesophageal reflux is defined as the regurgitation of stomach contents, primarily acid, back into the esophagus, and gastroesophageal gastroparesis is defined as delayed stomach emptying. Children who vomit frequently because of gastroesophageal reflux or gastroparesis are at risk for complications, including ulcerative esophagitis and Barrett's esophagus, which is a change in the lining of the mucous membrane in the esophagus. These complications are important because ulcerative esophagitis may lead to esophageal strictures, and Barrett's esophagus may lead to esophageal cancer at an older age. Some children with CDKL5 seem to have an unusual pattern of chronic vomiting, unrelated to gastrointestinal problems and resistant to usual therapies. In some children with CDKL5, chronic vomiting seems to be related to central nervous system irritability and may respond to different anticonvulsants, or the chronic vomiting may be related to metabolic disturbances, including acidosis and ketosis, and may respond to an increased amount of carbohydrate in the diet. I become concerned when I see problems related to irritability for unexplained reasons, nighttime awakening with either vomiting or regurgitation, frequent wet or dry burps, feeding refusal, formula intolerance, poor weight gain, wheezing, or aspiration. Several tests may be recommended to evaluate gastrointestinal causes of vomiting. A thorough history may be sufficient to diagnose gastroesophageal reflux or gastroparesis. An upper GI series, shown on the left side of the slide, evaluates the structure and to some extent the motility of the upper gastrointestinal tract. Esophageal impedance with pH probe monitoring identifies the frequency and duration of acid reflux. A gastric emptying scan identifies the presence of delayed emptying of stomach contents, a problem that may aggravate gastroesophageal reflux. The treatment approach for vomiting due to gastroesophageal reflux and gastroparesis is fourfold: diet, position, medications, and at times surgery. Dietary modifications include the removal of spicy food, chocolate, caffeine, and citrus foods from the diet. Children with reflux should maintain an upright position for 30 minutes after eating, and the head of the bed can be elevated 45 degrees during sleep. Antacids and H2 receptor medications buffer acid production, but they tend to be cumbersome to administer and ineffective in response. Proton pump inhibitors offer a better treatment choice for reducing acid production and protecting the esophagus from inflammation. Prokinetic drugs are supportive medications that may promote intestinal motility. And finally, a surgical procedure called a fundoplication may be recommended when medications fail. The third problem I want to talk about is constipation. Constipation is defined as difficulty with defecation. It's associated with straining, and it's a problem that lasts for more than 2 weeks and causes distress in both the children and the parents. Bowel movements usually are fewer than 2 times per week, and stool consistency is described as small, hard pebbles or large ball-sized stools. The cause of constipation is multifactorial, including familial, the consequences of neuromuscular abnormalities such as Hirschsprung disease, secondary to endocrine problems such as hypothyroid, and can be drug-induced, including some seizure medications. The complications of constipation include fissures or tears at the bottom of the intestinal tract, fecal impaction or blockage, and overflow incontinence, which is really diarrhea seeping around a large obstructive ball of stool. I become concerned when I hear symptoms such as bowel movements that occur fewer than 2 times per week, a change in stool consistency, either hard or watery, blood on the surface of the stool, abdominal distension, discomfort and pain, increased gas production or diarrhea, recurrent urinary tract infections, feeding refusal, and vomiting. Several diagnostic tests may be recommended. However, a thorough medical history and an abdominal exam, including a rectal exam, may often be sufficient. An abdominal X-ray, such as the one shown on the left, may be obtained to assess stool burden in the colon and fecal impaction. The haziness shown on the bottom of this X-ray is actually a large stool impaction in this particular child. A SITS marker study uses small radiopaque donuts that a child can ingest to assess colonic motility. A barium enema is an X-ray that assesses the structure and the function of the colon and the rectum. Rectal manometry is a function study to look at the muscles at the end of the gastrointestinal tract. A rectal biopsy helps to evaluate the presence or absence of nerves that affect colonic motility. And a colonoscopy with biopsies assesses the presence of inflammation. The treatment approach to constipation is threefold, including dietary modification, medications, and surgery. Dietary fiber such as fruits and vegetables and good cereal is important, but natural remedies generally are insufficient in children with CDKL5. Sorbitol, which is a non-absorbable sugar in prunes and pears, may be a useful additive. Probiotics that include lactobacillus and bifidobacterium may promote good bowel health. Medications that soften the stool, push the stool out, or what I call pull, in combination or alone each, usually are required to support good bowel habits. Common laxatives include the polyethylene glycol, lactulose, or mineral oil, which function as softeners, and milk of magnesia or senicides, which function as irritants and help to push the stool out of the colon. Suppositories or enemas that pull stool out of the colon and rectum may be necessary as children become older. There are newer drugs on the market, but they are limited to adults with constipation. These drugs facilitate bowel emptying through a mechanism called chloride secretion, and they are limited to children who are over 18 years of age. Rarely, a surgical procedure, either a cecal button or colonic resection, may be required if the medical management fails. In summary then, GI problems frequently complicate the clinical course of CDKL5 deficiency disorder. Gastrointestinal symptoms may be more debilitating than the underlying neurological problems, and any symptom that causes parental concern should be evaluated. Treatment strategies should be implemented to resolve symptoms, avoid complications, and improve the child's health and quality of life. Thank you. We're done.
Thank you, Dr. Motil.
No, sorry for the coughing, but at my old age, I get very